Hello, I'm Bob Garvin. Welcome to Body Talk, episode 82. A flawed study about flossing is about to be ripped to shreds. We'll also take a look at a potential cure for hiccups. My special guest today is Ophthalmologist Dr. Charles Barsam. If you have any questions or comments about this podcast, send an email to lifestarmedia@gmail.com. And we're excited to announce that Body Talk is now on Facebook. Get the latest medical studies, commentary, learn some new exercises, and hear some podcast outtakes. You can find the page by logging on to Facebook and typing in @BodyTalk Bob Garvin. Poor reporting, flawed study, and bad advice. I'm talking about a recent study that says that flossing your teeth is not beneficial. This is a bogus study offering bad advice that should be ignored. The study by the Associated Press claims that flossing does not reduce tooth decay and should no longer be recommended. The American Dental Association disagrees and says that flossing loosens up plaque before it can cause decay. A Cochrane review has presented evidence that flossing reduces gum disease. And a review of 6 trials found that when professionals flossed the teeth of children on school days for almost 2 years, they saw a 40% reduction in the risk of cavities. One of the problems with this study might be that many people are just poor flossers. Think about dental hygienists. They hug the neck of the tooth and they get below the gum line, while most people tend to lightly give the teeth a once-over. One of my personal training clients is a dental hygienist, and maybe her experience sums it up best. She tells me she can always spot a person who doesn't floss just by looking at their x-rays. Non-flossers, she tells me, get tooth decay where the teeth meet, a place where toothpicks and toothbrushes can never reach. So if you want to keep your teeth, keep your floss handy and ignore this ridiculous notion that flossing has no benefit. Okay, let's turn away from teeth and to the eyes with my special guest, ophthalmologist Dr. Charles Barsam. Dr. Barsam practices medicine at Mount Auburn Professional Services at Belmont Medical Associates. Dr. Barsam, let's talk a bit about cataracts. I know that the aging process is one of the leading causes of cataracts, but can sunglasses help protect us from developing this cloudy vision?
Bob, I think that although, again, in the extreme case, it's clear that ultraviolet does induce cataracts, when you look at the most prominent effects in America, they're usually not attributable to sun exposure. It would be very difficult to run a study looking at this in an empirical way, just because of the numerous confounding variables. However, it is my concern that if you looked at the most common cause, for example, in the United States, you would find that it ends up being, as you pointed out, first of all, age, secondarily, comorbid illness, and that would be diabetes, the use of steroid medication for, say, a patient who is dealing with a transplanted organ, medications, and then nutrition plays a very crucial role. So patients who are deficient in antioxidants, for example, have been demonstrated to have much higher rates of cataract progression. We're now learning a bit more about the role of simple sugar even.
Are cataracts inevitable?
They are, because they represent a natural evolution in the anatomy of your lens. So to some extent, I tell my patients, if you have enough birthdays, you're going to get one.
And when are they a problem? Is it just should you get them taken care of right away, or you wait until your vision becomes too clouded?
The cataract does not need to be treated upon initial diagnosis unless it is typically causing some difficulty with the patient's sight. So I like to tell patients, you will develop this as a natural consequence of the aging of the eye. However, it is not until the patient typically becomes symptomatic, meaning that they would have some blurring of sight, difficulty seeing street signs while driving at night, difficulty seeing fine print, these are the symptoms that usually prompt patients to have a discussion with their practitioner about the appropriateness of cataract surgery. My father practiced ophthalmology for approximately 45 years, and in his day, the intervention to have the cataract removed was very invasive by today's standards. Patients would spend up to a week in a hospital following their procedure. Today, the cataract procedure has been advanced by significant improvements in the technology that allow it to be done as a day procedure. The procedure takes usually no more than 15 to 20 minutes to perform. The success rate is staggeringly high. So, by yesteryear's standards, the patient would nearly have to be blind to justify the risk of the intervention. By today's standards, we're able to optimize patients' sight at virtually any age.
And when you do that, you're replacing the lens inside the eye. And I understand that there are some lenses that are flexible and claim to have a patient be able to regain all vision, close for reading and far away vision as well, essentially getting back youthful vision. Is that true?
The use of what are called advanced technology intraocular lenses has been what I consider to be one of the greatest advancements over the past decade in ophthalmology, and it has become a focus for myself and this particular practice. My experience with these lenses has been voluminous, and there are multiple different lenses that are appropriate for different patients. First of all, let me just discuss what you're describing in a little bit greater detail. The essence of a cataract treatment or surgery is that we will remove the patient's clouded lens or cataract and replace it with a new intraocular lens. And virtually every single cataract procedure done worldwide over the past nearly 50 years has been done with an intraocular lens replacement. Over the past decade, the technology that has been invested in these lenses has borne incredible fruit. And for certain patients, and obviously patient selection is crucial, a particular lens can provide patients with a greatly expanded range of vision. The lens that you're referencing and others have been used in my practice for nearly a decade. My own personal preference is what's called a multifocal lens, as opposed to what you described, which was a flexible or presbyopic correcting intraocular lens. It is my sense that the multifocal lenses provide a more reliable outcome and are safer for patients in terms of the long-term health of their eye. Yet nonetheless, the other lens that you're referencing was a pioneering advancement in our field and has been used successfully in tens of thousands of patients.
People almost be rushing to this to get their youthful vision.
Well, it is remarkable because I cannot think of any other procedure in all of medicine where we can take a patient and make them better than they may have ever been in terms of their functionality. And cataract surgery really is a unique model for not just getting back to the way it was, but maybe actually improving, rendering a patient, as you said, spectacle or glasses free indefinitely. And that's an exciting conversation to have with a patient.
What about these eye vitamins that you see advertised, and they're quite pricey as well, purported to help you avoid macular degeneration? Are these useful?
There was an important study that was actually conducted at Massachusetts Eye Ear Infirmary that looked at the role of nutrition in helping stave off progressive macular degeneration. And because this is becoming such an important public health issue for our entire country, the United States Division of Ophthalmic Investigation, something called the NEI, or National Eye Institute, did a study looking across the country at the role of multivitamin supplementation. They looked at what is called the AREDS formula, which refers to the particular cocktail of vitamins and nutrients that you would find in the eye vitamins sold, for example, at any pharmacy. And they tried to establish who would benefit from this and who is wasting their money. They subdivided this study into three primary groups. One cohort of patients had essentially minimal or no macular degeneration. A second had moderate, and the third that had severe. And it was only found in the course of a 5-year study that those patients who had either moderate or severe macular degeneration benefited from the use of the multivitamins. So my concern is that these are being marketed as prevent the disease onset, and that was never shown scientifically. If we get back to the basic study design, they looked at patients who actually consumed high amounts of fruits and vegetables and extrapolated that it was particular nutrients from those fruits and vegetables that conferred the benefit. So it is probably more advantageous and more absorbable to actually just eat those fruits and vegetables. And those that were established were, in particular, green leafy vegetables, broccoli, kale, Brussels sprouts, and spinach, for example, and brightly colored fruits, for example, papaya, mango. These are definitely in keeping with the health of the eye.
Talking about protecting the eyes, and we talked about sunglasses. A lot of women don't like to wear them and like to wear visors instead, or maybe like baseball caps. Would that provide enough protection for the eyes, just a visor?
It provides protection from what is called direct sunlight. However, in some instances, a more harmful form of the ray of sunlight is the reflected light, in particular off of water. So if you're wearing the visor, you're only protecting that direct ray. You're not protecting your eyes from the reflected ray that's bouncing off of, for example, the salty ocean water and intensifying as it hits your eye.
Would that also bounce off of hard surfaces as well?
Absolutely.
Something else you keep hearing a lot about glaucoma, and do we know what causes glaucoma?
If we did, we would be better off as a profession. Regrettably, we have a deep sense of understanding certain mechanisms of glaucoma and being able to treat the condition. However, the specifics of the disease are still somewhat elusive. The way we try and explain the disease to patients is that it is typically a pressure-related disease, meaning that our eye has an intraocular pressure in the same way that we have a blood pressure. And just as we understand that elevations of blood pressure could harm your heart, we understand that those elevations of eye pressure can damage the optic nerve, which is the cord that interconnects your eye and brain. So protecting that tissue is crucial to preservation of sight. The problem, Bob, is that it's not that simple, and that there are types of glaucoma where patients do not experience elevated intraocular pressure and can have degradation of the optic nerve despite what are considered normal pressures. So if we simplify the disease and just think about it in terms of an ophthalmological analog of systemic hypertension, we're really trivializing the complexity of it. So we've put a lot of effort in my practice and in many others to different manners of diagnostics to help understand the effect of a particular pressure on the eye and to look at the eye in a very careful manner so as not to overlook the more subtle manifestations of the disease.
Is there hope for somebody with glaucoma? I mean, are they looking at blindness, or can they live years or decades and still maintain a nice level of vision?
In most instances, patients who are afflicted by glaucoma can expect to have a lifetime of excellent sight. And again, harking back to my father's experience, in his day, it was very challenging to diagnose, especially the more subtle forms of glaucoma. So glaucoma would present with vision loss. Many patients still carry those fears with them as they think of a loved one, maybe an aunt or a grandmother, who suffered from the blinding form of the disease. Because we are now able to screen and look at the eye in a much more sophisticated manner, that's usually not the case. My description of the condition to my patients is that upon early diagnosis and treatment, usually this is something you will live with. It's something that we'll treat, but it is not something that's going to impact your functionality.
Macular degeneration, I just keep saying this coming up all the time, is one of the leading causes of blindness. And where are we with the treatment? First off, do we know what causes it? And then can we treat it? Can we avoid the inevitable blindness? Is blindness inevitable?
Well, getting to the first point, do we know what causes it? This has been probably the hottest area of research and treatment in ophthalmology, and in the history of our profession, there has really never been, in my estimation, or rarely has there been, the level of sophistication and advancement of treatment that we've seen again over the past decade. New medications have enabled us to take what used to be an inevitably blinding disease and make it a manageable chronic long-term condition where patients can enjoy excellent sight. Again, this is a complex and multifactorial condition that can be influenced by genetics. It can be even influenced by a patient's eye color. We know that, for example, women are more susceptible than men. Some of that may be due to the bias of females living longer than men. Nonetheless, there are other factors as well. A patient's cardiovascular status. We know that patients who have what is considered to be small vessel disease, who suffer from high blood pressure, kidney disease, diabetes, some of these things can induce damage to the small vessels of the eye that in turn feed the nutrition to the retina, and that can induce macular degeneration. Because we have a more robust elderly population today, we're seeing a greater incidence of the disease. And our patients, even in their latter years of life, are enjoying wonderful, full, and healthy lives, and they don't want their sight to limit them. So thankfully, one of the greatest advances, as I said, in our field has been the capacity to treat the active, or what's called wet form of the disease. And that's now done routinely. Indeed, this has probably become the most common treatment in most ophthalmological offices over the past decade.
Thank you, Dr. Barsam, for joining me today on Body Talk. Finally, could this be a cure for the hiccups? Experts say that there's a technique that works by resetting the diaphragm, which stops the hiccups. They say it takes 4 steps, and they must be followed to the letter to end the cycle of hiccups. The first thing you do, they say, is breathe in as far as you can, filling the lungs with air. Next, when you think you've breathed in as far as you can, try and suck in a bit more air with a little inward gasp. Then hold this breath in for a full 10 seconds. Before you breathe out, swallow. That's all it takes, they say, to stop the hiccups. Well, that's it for this edition of Body Talk. My producer is Katie Stell. The Body Talk theme song was composed by Rob Carlson and sung by Vicky Vox. If you'd like to stay up with medical studies on a daily basis, follow me on Twitter at BGPVideo. And if you have any questions or comments about this program, feel free to send me an email at lifestarmedia@gmail.com. Body Talk is a production of Lifestar Media.